Dr. Linda.
Hi, good afternoon. Are you all back?
So you will start with what is your next session?
So now we're going to do HR retention, still on organizing.
This is also belong to the management care process?
Yes.
Yes. So where is the first part of the lecture? It is recorded already?
Yes. Who's speaking now?
Dr. Saeed Al-Amoudi.
I said yes, it was recorded already.
Thank you.
So good afternoon, everyone. We'll start again. We'll start with the second function, which is organizing, looking now at HR and retention. I think as healthcare leaders, we know the importance of retention because of the current situation that we are currently in. It is vital for us to ensure that we have retention strategies in place to keep our key players in our organization. So retention of a positive and motivated employee is very important for organization success. High employee turnover increases the expenses and also has a negative impact on organization's morale. Performance and productivity maintenance, employee retention practices help support an organization's productivity. There's been a lot of studies over the years as to why top employers retain employees. And as you can see from the result, 73% have a personal development plan. So it's essential for any organization to make sure that you have a development plan in place for all your personnel in order to retain them. 87% implement workflow measures, 97% offer coaching programs, and 71% offer innovation awards. 80% offer job enrichment programs, and 77% use technology to help employees define career development. So on that, let's have a little bit of a discussion as to what do you think as a leader or a manager? What strategies can you utilize to retain employees? Anybody?
Motivation.
Motivation is one, yes. What else?
Clear job and responsibility.
Yes. What else?
Flexibility.
Flexibility. So there's different
providing opportunities for professional growth.
Yes, opportunities for professional growth. What else?
Recognition.
Yeah, recognition. So
career planning.
Development planning, all of them are very essential. So recognize staff's achievements, give workers a purpose, engagement in unit activities and more responsibilities, provide opportunities for employees to relax, have a positive culture in your organization. It's essential for you to look at your environment and have flexible scheduling, teamwork, communication, leader visibility. These are all essential components that will create a positive environment. Improve engagement, foster teamwork and communication, invest in education and continue learning, and then provide competitive compensation. You saw that I've put provide competitive compensation at the bottom because ultimately that requires top leadership, and often because of the financial constraints, it might not be always possible. When we look at education and training, obviously it's essential because we saw from the retainment strategies that learning and development can increase employee retention, job satisfaction, and productivity. It's a vital tool when implementing new policies, equipment, and employees. And newly developed dedicated learning time supports improved patient care services to your community and allows for career development. If we look at how to develop a strategy for building development, first of all, it needs to be part of the strategic planning. Development needs to always be included in a strategic plan because it's something that we have to focus on from top level. We have to make sure that we have a program in place to assess the skills and the competencies. And for physicians, obviously, it's looking at privileging. Potential need and priority identification. What are some of the needs that the employees might need from an operational level that they potentially might not have the skill in, that they require special training? And for nurses, we have annually, towards the end of the year, we have a learning needs analysis that we do. And then based on that and incident reporting, we then plan our educational needs for the next year. We look at training and capacity development. We implement these arrangements and then we monitor and evaluate. So it's a cyclic process, but it's very involved, and obviously you have to evaluate the program on an ongoing basis based on needs. If you look at this tool, it's again looking at your strategy, capacity development, motivation, and then making sure that you have a culture. That way you allow for developing your team and making sure that you have the right people working in an organization to provide the services for the patients that they require. There's different kinds of staff development programs out there. If you look from top management model, these are the initiatives that's taken at the top and that's imposed on lower layers of the organization. And it specifically is when we have policy changes or where there's safety events and they require us to follow, or where the regulators are telling us that we need to do certain things. So it's very much driven by regulation and safety. Bottom line, this is coming from the bottom up. These are initiatives that's taken from the floor level by the direct care providers. And it's often when we identify an issue in the unit and the team are working towards process improvement. And when we have a partnership or a collaborative model, these are the initiatives that's jointly managed by the staff in a collaborative way. And it's very much looking at a shared governance model that especially is required from magnet facilities. Looking at staff in education, what do we think should be included in a staff plan? So we know that it is required. Every employee that comes into the organization needs to have a formal orientation program, and many has a specific hospital orientation program where they will talk about specific things regarding the hospital compared with the HR, looking at safety, looking at quality, what are the confidentiality and diversity issues that the team needs to be looking at, and also addressing some of the infection control practices and ergonomics that is essential to keep the employees safe. Then you also have unit-based orientation program, which is really helping the employee to be practicing in the environment that they're going to be doing direct care for. And that is very essential. I can talk about nursing because I'm a nurse myself, and I think here we truly look at the unit and some of the processes and systems that obviously they will be working on. We also have to look at cross-functional training because we are losing a lot of key players, and we know that a nurse is not a nurse and a doctor is not a doctor. So we have to make sure that people are cross-trained and that they are able to provide the service if somebody is leaving the unit. Constantly, we have to, in nursing, make sure that we maintain some of their professional skill. So mandatory training is essential for any employee. And we have to make sure for nursing that certain competencies, whether it's an annual competency or every 2 years, we have to make sure that we assess it and that the employee is still able to function at a level that will provide safe care. Coaching needs to be available because we have to have structures in place where we oversee how people are performing. And also, if we see that they are not performing within the regulations and the policies of the organization, we have to direct and guide them to make sure that they understand that they haven't done something correctly. And then we have to make sure that we have career development opportunities available, because everybody is driven by making their own careers and advancing in the career ladder. Personal development is essential, and we have a lot of in-service training opportunities available, as well as obviously CPD or continuous medical education units to ensure that we constantly have a program to develop people. We know that there are 4 levers for living, whether it's on the job, mentoring or coaching, training on continuing education, or motivated self-development. These are driven by different reasons, and as you can see, the majority is on the on-the-job experiences. So it's essential for us in our industry to make sure that we provide those opportunities and give the people opportunity to learn. This is just talking briefly about the orientation team, whether it's the coach or the mentor, and it's essential for any new employee to have a coach, especially if they have changed the job. So it's guiding a person to improve job performance based on a specific content, and collaborate with a person to establish goals for the future. A mentor provides a supportive and guiding relationship and focusing on building a relationship and supporting career development. So we know that it's essential, and we know that there always needs to be a return on investment. So what do we get out of it if we invest a lot of time on educating and training our employees? So first of all, employee retention. Staff members develop loyalty to a practice because they feel that you care about them as individuals. They benefit from personal and professional growth and do not feel their careers have stalled out. Staff morale, a practice culture that encourages learning and fosters education, creates a positive, motivated and committed workforce. Practice efficiency is another return on investment, and orientation and cross-training are essential for smoothly running units. The stability can engineer that result from low staff turnover also contributes to efficiency. So more return on investments is job competency. If we make sure that we have proper functions in line and we provide specific training, people become more productive and they become more confident. Both clinic and administrative staff needs ongoing education to stay current regarding the constantly changing aspects of our practices. And patient satisfaction. Yes, staff education affects your patients who benefit from your employees' skills and obviously positive attitude and efficiency. Employees also feel they make a difference and in the mission do better work. So you can see from all the positive things that you can gain in educating and training your employees. So it's essential for us as healthcare leaders to constantly think of all these factors that provides a return on investment for us and what is the best for the organization. This is just a conceptual framework for the American Nursing Credentialing Center, looking at nursing professional development and continuing nursing education. They obviously have a structural capacity where there's commitment, accountability, leadership, and resources that is assigned to making sure that you design educational processes that oversee the assessment of learning needs, planning, and there's a faculty to oversee the education that needs to be designed. There's design principles to allow that all the learning needs is addressed, and there's specific achievements for the objectives that has been set. And obviously there needs to be quality outcomes. So you have to constantly evaluate your process, you see the involvement, you set goals for improvement, and you make sure that there's professional benefit. The next component that we will be looking under the organizing structure is staffing. Now we know staffing is an essential and vital important in the management of care processes. So a staffing plan is a required element, and it's normally set by the corporate body at a more advanced level, and your leader or your HOD will be the one that will be forming part of those decisions. So it's an essential element. It's part of the strategic process by which a company assesses and identifies the personal needs of the organization. A good staffing plan helps you to understand the number and types of employees your organization needs to accomplish its goals. So in your organizations, from the different fields that I've been listening to, what kind of involvement did you have in your staffing plan?
Sorry, again, the question?
So you are Dr. Ibrahim, right?
Yeah.
Yeah, so Dr. Ibrahim, you are a nephrologist. So in the nephrology department, how were you engaged to talk about the staffing needs for your department?
Sure. According to the patient ratio. So for 120 dialysis patient, for example, it's supposed to have one consultant, two specialists,
yeah,
and also nursing ratio, one nurse to 3 patients.
So in every, it doesn't matter in what entity we are working, everybody is using a special formula or a method in how they attain or a certain staffing. But what we have to understand with a staffing plan is it needs to answer the following question. What work needs to be done? How many people do we need to employ? And Doctor, you spoke now about the ratios that's required. For any staffing, there's a formula, and you said for the specialist, there's obviously one based on so many patients and one nurse for every assigned to every 3 patients. So the same kind of thing is available also for the inpatient care units. And I will be posting the formula online because one of the questions is actually talking about the formula and asking you how to work out staffing for an ICU. So it's basically looking at the beds that you have in the organization, multiply by the occupancy level for your organization, multiply by the days of the year, multiply by your hours per patient day, and that then you multiply that with your hours that you need to work for the year, and then you divide it, and then you get your FTE that's required. So I will put the formula up onto the site so that you can have a clear understanding as to how it needs to work out. Even for annual leave, there's a formula that we can use, and I will put that annual leave formula as well available, because as we plan our staffing needs, we need to look at all these factors. What skills and experience are necessary to do this work? And what skills gap needs to be filled? Is there anything extra that we require, or is there any redundancies? and in what time frame do they need to provide service? Because we know if it's a 24 service, you need to make sure that there is enough staffing to cover for the entire time frame that you provide the service for. We know that there's legal compliance relating to staffing, and because we are working in the boundaries of the United Arab Emirates, we have to follow with the legal requirements that binds work in this country. So when an organization acquires people to do work for it, legal employment relation is established. The acquired people may be employees, independent contractors, or temporary employees. And laws are needed to define how the employer may use each type as well as the right of each type. Laws have been developed to create fairness and non-discrimination in staffing, such as race and discrimination and disability. So just going back to here, what are some of the legal laws that governs staffing relating to healthcare in particularly? What are some of the laws that apply? We have the labor law, right? The labor law clearly dictates our working hours, if we have disciplinary needs, if you're talking about gratuities. So our labor law is there to protect us and also to protect the employer. What other laws or regulations govern our practices?
I think most important one in healthcare, confidentiality.
Yes, confidentiality.
For information of the patient, for...
I'm talking specific, doctor, sorry, specific to staffing.
Yeah, to staffing, yeah.
So in one in particular I can think of, for physicians, I know there is the medical law, because of if there is a case against a physician that they are protected. So there's specific insurances and things to protect them. We also have the Ministry
Malpractice.
of Health, or we have Department of Health, that requires us to have certain qualifications, right? Before we can even start in a hospital, there's certain qualifications we need to have. Sorry, I heard somebody else talking.
No, just I said malpractice insurance.
Yes, that's the malpractice insurance I was talking about. And so we need to know that the government is requiring us to be licensed to practice in the UAE. And before we can be licensed to practice, we need to provide certain qualifications based on the role that we are employed for. So there's certain terms used in staffing that I'm just sharing with you. It's for your information only, but sometimes you'll hear it in a discussion and it's just nice to know. Job specification is a statement of employee characteristics and qualifications required for satisfactory performance of defined duties and tasks comprising a specific job or function. Job analysis is the process of gathering and analyzing information about the content and the human requirements of job, as well as the context in which jobs are performed. This process is used to determine placements of jobs. The analysis considers the areas of knowledge, skills, and abilities needed to perform that particular job. And then a job description is something that each and every one of us needs to have, because it's a written narrative that describes the general task or other related duties and responsibilities that a position is requiring. So why should we apply effective utilization of resources? We know that we're following a lot of pressures because of cost increases in medical supplies and pharmaceuticals, record shortage of nurses, pharmacists, technicians, and physicians, a growing uncompensated patient pool, annual potential reductions in medical insurance reimbursements. And I think if we're working with medical insurances, we see that there's a lot of denials coming through lately, and our hospital's insurance and finance department has a major issue in getting the money for the services that we provide. Rising bad debt resulting from greater patient responsibility for the cost of care, the diversion of more profitable cases to specialty and freestanding ambulatory care facilities and surgery centers, soaring costs associated with adequately serving high-risk conditions, discounted reimbursement rates with insurers, increasing pressures to commit financial resources to clinical information technology, and the need to find infrastructure improvements and physical plant as well as expansions to address increasing demands. So we can see that there's a lot of things that we as healthcare leaders need to be looking at because of the fact that our resources is so scarce. We have to make sure that we employ specific measures to utilize our resources effectively. This is just showing nurse staffing quality and care of outcomes, and it's a nice demonstration, and I think you can even change it to a physician, where we're really looking at what are the kind of things that we have to look at when we have a person assigned to a certain unit, because ultimately the outcome needs to be that they provide safe patient care and help us reach our goals. There are different models and things that we can utilize to effectively utilize our staffing more effectively. And this is a staffing matrix, for example, that we can use to staff up and down based on our volumes. So if you can see, if we now look at this tool, if we have 12 patients in the hospital, we know that we need 3 RNs and 1 healthcare assistant to be on duty. So that really helps you to go down in staffing, because you don't need to have so many staffing, and it's both for night and day shift. And it also allows us to, when we're coming to a certain number of patients, that we think whether we should be keeping that unit open or should we move the patients to other units. There's also a lot of other tools and electronic devices that's available that organizations can utilize to look at effective utilization of resources. You can be looking at some of these tools that's available on the market. Next portion of organizing is performance appraisal, and we all have to have an appraisal once a year. I need to remind everybody, this is not a once-off process, it's a continual process where we have to review the employee's performance right through the year. And the great thing with a performance appraisal is that along the way, if we have identify a gap, we have to change whatever practice the person has and make sure then that they fix it. It's got a set of expectations, we invite comment, we measure their process, we provide feedback, we link it to consequences, and obviously evaluate effectiveness. The performance appraisal is a process of evaluating employee performance. We look at specifically at their job-related strengths. What did they do well in? Did they contribute to process improvement activity? Are they part of a link group? Are they making sure that if you're looking at their documentation all the time, the documentation is accurate and it is complying with the policies and procedures of the organization? If you've identified through the years any development needs and you've put them on a corrective action plan and they still didn't progress, you have to develop it. And you are identifying how did they progress toward that needs. And sometimes it helps with pay for promotion decision. It's more systematic as betting for the most of the part. And this is just talking about the different kinds of performance appraisals out there. I think that many organizations have either graphic rating scales or checklist scales, and some actually have online performance appraisal systems. So whatever performance appraisal technique is utilized in your organization, it allows you to provide an effective manner in looking at how your employee is performing right through the year. I think you have to understand as well, and I think we didn't have a lot of time, so you have to go and see what is some of the advantages and disadvantages with these different types of performance appraisals that's out there. We know that there's a lot of benefits for a positive performance appraisal. Obviously, it assists to enhance employee performance. You integrate the employee's performance with the strategic vision. It can also be utilized to hike salary and compensation, and it helps with promotions and transfers. And the tool is really there to inspire the team for advancement. So how do we manage staff performance? Obviously, the first step is to establish performance expectations and standards. This is something that you as the healthcare leader need to set from the beginning of the year. People need to understand what you are expecting from them. You have to link it with the strategic objectives, and then you have to set goals, whether you want to improve hand hygiene with 10%, whether you need to improve documentation. Those kind of performance measures and goals needs to be set from the beginning of the year. You have to provide regular feedback. I told you in the beginning that performance appraisal is not just sitting at the end of the year and giving people feedback. It's looking right through the year and using the patient care information and key performance indicators to see how we are doing as a team. You measure actual performance by looking at whether they are meeting the standards that's required and doing their documentation all the time, and that there's no negative actions. And you also use, if you've put them on an action plan and you've spoken about their documentation and they haven't approved, it should be part as well of the appraisal. You compare actual performance with standards, and you discuss your results of your appraisal towards the end of the year. And then obviously you come up with corrective measures and new goals that the person needs to achieve for the new year, and then you conclude. Obviously, with the performance appraisal, the most important thing that we have to look at is, for nursing especially, we look at whether they have completed all their competencies for the year, and everybody needs to have valid ACLS, PALS, and other life support trainings available, because that is a requirement for our licensing body. So just to overview again, the feedback, when we look at performance appraisal, is feedback that we provide to the staff timely and meaningful, and it's a reflection on what is required of the person to do their job. What does high performance look like? You're setting the goals, you develop by identifying and planning learning needs, you review by formulating and evaluating progress document, and you show them the performance result, and then you reward them for a job well done. This is just showing us that job analysis, performance standards, and performance appraisals goes hand in hand. So it always needs to be considered when we are hiring an employee, because those performance standards needs to be set for the job that we are adhered to. This is a reward and recognition model that is utilized in some organizations, and I think it's essential for us to realize that everybody wants to be rewarded. And if you talk about people, they always say that their boss didn't say thank you, or their boss didn't reward them for something that they have done a remarkable job at. So we are humans, we want to be recognized, and we have to make sure the same is evident in our work environment as well. So we need to have those strategies in place to make sure that we have reward and recognition programs that address that. I know many big companies actually have specific programs available. For us, for instance, we have a employee of the month, so you can have the same kind of thing, or you celebrate if somebody has completed their master's or some sort of a degree, you can recognize as well. So what kind of programs are you using to reward your staff in your own organizations?
Like in our hospital, we are utilizing a well-being program.
Very good. Anything else?
In our hospital, we do have a Daisy Award.
The Daisy Award. Yeah, the Daisy Award is quite popular in many organizations these days. And I think it's a wonderful award because it really is based on certain standards, and employees really has ability to showcase all the good things that they are doing. Many organizations also have like a safety award if a person identifies and prevent a harm from reaching a patient. They actually have a program to recognize that employee. Going into function 3, which is looking at the leading function of a nurse, of a manager, and it's looking at emotional intelligence, the different leadership styles, communication, teamwork, relationship building, and delegation as part of those functions. So emotional intelligence has really done a lot of work over the last few years from the behavioralists. And they have really looked at how this plays a major role in how we have to manage our employees. First of all, our own skills in order to manage those that we have to lead. So EI is the ability to understand and manage your own emotions and those of the people around you. People with high degree of emotional intelligence know what they're feeling, what their emotion mean, and how these emotions can affect other people. We know that there is 4 different functions that is under emotional intelligence. First set of skills is the self-emotional skills, where we as healthcare leaders need to understand us and be aware of our own self, how our emotions is affecting us, and then utilize that to guide and develop others. And then looking at the intrapersonal is where we developing human potential and performance. So this is where we're developing our employees. Relationship building is one of the most important functions for emotional intelligence because it's really managing excellence. It's really looking at managing conflict, managing decision making, managing relationship, making sure that you develop others, making sure that you have a vision. And that's why this is one of the essential things. And the socioeconomic factors is really looking at what do we need to do to make sure that everybody is aware of being part of the team and their relationship that is required in teamwork. So why should you know about emotional intelligence? 70% of the reasons for losing clients and customers are emotionally intelligent related because of poor service, poorly handled complaints, unpleasant interactions, and people didn't go the extra mile and there was no follow-up. So it's essential for us to understand that a lot of times, and as we are in a financial crisis at the moment, and if we are in an industry that is requiring our clientele, we truly have to make sure that we utilize emotional intelligence to the benefit of our organization. And then lack of the human connection. So can you hear me now? Lots of time people are saying people are not listening to them. Unsatisfactory team leadership during challenging times. The leader is not visible, inability to handle interpersonal issues, and inability to adapt to change, and inability to elicit trust. I think as you can see from this, these are all the kind of things that sometime during our own work environments and journey we potentially have encountered feeling like this, and this is potentially why many people are leaving the organization. And 50% of time is wasted due to the lack of trust. So I think we can see from the couple of slides the importance of using emotional intelligence in the workplace and making sure that we utilize it for the best of the organization and for establishing a relationship. There is basic abilities. I like this model, and there's quite a lot of things in this model, and I want you to truly take a moment when you're going over your notes in preparing for your assignment, because I think it's so essential for us sometimes to be lost in some of the information that is out there in leading our teams, that we forget sometimes the most important thing. So there's a lot of leadership characteristics and behaviors that we have to be aware of. And these are all related to emotional intelligence. And as you can see, if we use feedback on social identities based on our self-awareness and self-regulation, it affects the team. And then it leads to certain team dynamics. It will result in certain team behaviors and then ultimately team effectiveness. So it is so essential for us to take emotional intelligence and just see just how it affects team dynamics and team behavior. Leadership. Leadership is a process of social influence in which one person can enlist this aid and support of others, the accomplishment of a common task. And it's ultimately about creating a way for people to contribute to making something extraordinary happen. So this is the leadership triangle. We know that we need leadership, we need followers, and we need management. And ultimately, it will lead to achieve effective and safe patient care. And I think as we go along, we will identify that there's certain attitudes and skills and attributes that we can assign to a leader and a manager. Just a question. Do you think you are a leader or are you a manager?
Leader.
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 Yeah, leader.
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 So I think everybody has stated that they are a leader. And I think sometimes if we are in healthcare management, we can argue, because I think we do sometimes have both leadership and management abilities. So if we look at comparing management and leadership, I think we have both of these characteristics that is required for both being a manager and a leader, because we do cope with complexities in our own environment where leaders are coping with change. We, as managers, we administer the policies and procedures and regulations that's required. As leaders, we are innovative and we are initiating the care plans on our different units. So there is a lot of things, and there's always controversy with regards to whether you are a leader or a manager. But I think you have to look at it that you are both. You cannot be the one without the other, especially if you are in a leadership role. You have to manage some time to make sure that you do the right things right. So leadership roles. We know that we are visionaries and strategists, organization builders, communicators, and motivators, and we'll discuss this in a little bit. So first of all, leaders as visionaries and strategists. Their role is to help create and define a vision for the organization and to motivate and inspire others to achieve the future. Leaders as organizational builders, their role is to determine corporate values and culture and then lead by example. Leaders as communicators, I think this is probably one of the most important roles that is often missed by all of us. One of the primary roles is to seek the most effective ways to communicate the vision to key followers. Leaders as motivators, their role is to empower, motivate, and inspire their followers to achieve organizational goals. We know that there are different leadership styles. So if you look at these different leadership styles, which one do you think you are? Which one do you think you are? You all think that you are democratic or visionary, coaching, pace setting. I think in any given time, we potentially can have all these qualities, because when it comes to policies and regulations, we have to be
situational leadership.
Yeah, so there's a different kind of leadership styles that is available. But if I have to look at this slide, I have to say that sometimes during your course of action, you have to utilize many of these that's on this slide. I always say that I'm a transformational leadership, but sometimes you have to be transactional. The democratic is very popular among a lot of people, but I think transformational is where we want to be. These are some of the different kinds of leadership styles available there with their advantages and disadvantages. I think it's just nice for us to know what the differences are and also to relate to it. But I think sometimes people think that autocratic is bad, but in some circumstances you have to have autocratic leadership, especially if there was an unsafe situation and you need the whole team to follow and change things. So there always needs to be a balance between the employee power and management power, because that way you will align and inspire your team to the right progression of work that is required. So when we look at the attributes of a manager, they monitor progress, they set direction and set expected achievements, and they show the team members where they fit in achieving unit goals, and they perform administrative tasks, and they report to senior management. Money and job security play a major role in management effectiveness, and they act as efficiency motivators. And we know that the concept of management is driven by target, and we assure that we are achieving the organizational objectives through executing the strategic plan. We always have thoughtful influence with our teams that we are trying to involve them in reaching those goals, and we motivate our teams. These are just unfortunately more the same. Apologies. And having what it takes to get the job done. And it's so true. We know that as middle managers, these are the most essential skills that we would need in our day-to-day activities. So it helps us to guide our direction towards what we need to do. This is a case study that was done a couple of years ago by McKinsey and Partners. Sorry, somebody's talking?
Yeah, conceptual skills. Previous slide.
Previous slide.
Yeah, conceptual skill. You mentioned there is a technical skill, time skill, critical thinking skill. There is one slide, one line is conceptual skills. Yeah, this one.
This one?
No, next.
This one?
Next one.
This
next.
one?
Next. Next.
Skill of the leader.
Yeah, skills of the leader. You mentioned conceptual skills. What meaning conceptual skills?
Where are you now? I'm trying to find where you are.
Next. You mentioned there is critical thinking skills. There is time skills.
Yeah, now I know where it is. I'll go there now.
Yeah, this one. Conceptual.
So in your line of duty, whether you are a nurse or a radiologist or a pharmacist, there's certain concepts relating to your field of practice, correct?
Yeah.
that is relating to that field of practice. So you need to have that experience and knowledge and skills for that particular field that you are in.
Sure.
Okay.
Thank you.
So this was a study that was done a couple of years ago by McKinsey and Partners. And the reason why I put it into the program is because as healthcare leaders, we constantly have to look at what is out there, what is driving our practices, how does productivity affect the bottom line, and also we need to know why it's important for us to evaluate our own performances. So this was done for over 6,000 people in an industrial firm, and they really looked at everybody's involvement and how their productivity has affected the bottom line. And as you can see that the data is truly suggesting that management really matters, because management practices is strongly related to the clinical outcomes, patient satisfaction, and the hospital's financial performance. There is a large variation between the UK and the US data. The UK healthcare management practices, the UK averages scores these others, and large intra-country variation creates a real opportunity for improvement. The improvements is possible. There were 5 factors that were associated with better management practices. Sharing of clinically trained managers. So it's important that, and I think often what is said is that we do a lot of training and development for our staff, but managers don't get the same kind of training opportunities. The degree of competition that there might be, the hospital size, managerial or autonomy, and hospital ownership. So there was a strong correlation with regards to certain things. So when they look at management practices, hospital operations, and they looked at different dimensions, and obviously they've taken different scoring from that. And then people were able to talk it, and you can see that 6.5% reduction in risk-adjusted 30 days of your acute MI mortality rates was identified. There was 33% increase in the income per bed and 20% increase in the probability that the hospital is above average in terms of patient satisfaction. So good management is definitely correlated with better clinical and financial performance. So we as healthcare leaders have a tremendous job to making sure that we get our team aligned and that we lead them to where they need to be. The next function we're going to be looking at is delegation. And delegating is assigning a task that you currently have in your activity list and then assigning it to another person with confidence that he or she will be able to complete it. And how do we delegate effectively? We need to first overcome a mindset that I can do it betterly. And if we do look at studies, often it is said that people don't want to delegate because they think that they can do things themselves better. Sorry about that. I think one of the major things for healthcare leaders is that we have to make sure that we empower and educate our team to become the better of themselves in order for you to make life easier in the unit. So why do we need to delegate? Obviously, delegation demonstrates managers' professionalism and effectiveness. It creates a win-win situation. The member gets some sense of accomplishments. They know that people are trusting them, and they get an opportunity to grow, and there will always be recognition, recognized based on what they're doing. If delegating is done well, a project manager can quickly build a strong and successful team of people, and they will be able to meet the demands of others. So what are the parameters to do delegation? First of all, obviously, it is important for us to understand that what is the complexity at hand. You cannot assign a job that is based on a scope of practice for a physician or a nurse and assign it to somebody that doesn't have that same kind of skill. The same kind of thing, if a person doesn't have the training, they should not be able to do that. The risk involved if not task is not completed as expected, and commitment and competence of the team members. These three things have to be considered before you can delegate a task. And the authority and responsibility obviously have to be also understood by who you are delegating the task to. So we delegate the whole job whenever possible, because this way we increase motivation, avoid upward delegation, we need to constantly check. We shouldn't be become micromanaging them, because what is the reason for us delegating in the first place? And always have progress checkpoints. Check the work progress in the right direction and give more confidence in timely delivery. So how do we delegate? Don't delegate if you don't know about the task, and don't delegate tasks that requires confidentiality or sensitivity issues. So we definitely will not be delegating certain things. So in general, you need to delegate to the right person. You have to be sure to delegate to the person with the right skills and capabilities based on your decision on talent, not convenience. Specify the result you want. Clearly communicate the result you're looking for. Specify what you want to look, and then you have to make sure that it's done. Establish the time frame in a realistic time frame, the date by which the project or action needs to be completed. If you are working in an inpatient unit and you're delegating a patient care assignment, obviously it has to be done within that time frame that the specific task needs to be done. Determine the team's level of authority, how much authority your team has in terms of taking action and making decisions, and track the progress. Set up reporting and communication systems to know when things are completed, and be available to problem solve. So there's a lot of things that we can delegate, but certain things cannot. So all non-management tasks can be delegated, tasks with which you can pass authority, tasks that boost an employee's skill and challenges them, and tasks that are paired with the person's abilities. You don't delegate tasks that an employee does not have the skills to complete, and also if that are busy work. That's called dumping. Tasks which are constantly detailing out instructions for, and tasks should not be constantly delegated to the same individual, otherwise they would feel that you are targeting them. Tasks that involves personal issues. So obviously things with regards to coaching and counseling, these are things that you will definitely not be assigning to somebody else. There's a distinct difference between delegation and dumping. So delegation, you examine your task, you coordinate the task, you assign the task, you support and provide feedback, and then you reward completion. Dumping, on the other hand, is handing off work that the supervisor doesn't feel like doing, and passing responsibility and accountability. The next portion of leading that we will be addressing is teamwork. Teamwork is an essential component of how we function in healthcare. We cannot be working in our silos, or as a nurse or a physician. We need each other and also our support team to make sure that our patients receive the care and services that they need. One leader with 2 or more people who share a common goal is called a group, and teams of 2 or more people all lead and share a common goal is a team. In a team setting, every member has a sense of ownership and responsibility. If we look at the code team, the code blue team, for instance, you know that in a code blue team, every person is assigned, whether you're the first responder, second responder, third responder, or whether you are assigned to medication or to recording. Each and every one has specific roles and responsibilities in that team. There are different stages of team development. We will merely going over them in order for us to understand what they are, because I think even though we are working with a team for a while, if new people are coming in, you will probably see that people are going through these different stages. Forming stage is getting to know and form initial opinions about team members. The storming stage, some team members begin to have conflict with each other. And the norming stage, team members accept each other and overcome the conflict. The performing stage is where we are all working well together on the task. And the adjourning stage is when the team completes tasks and brings closure to the project. So how do we build a team? First of all, we need to understand what a great team is. We need to make sure that we set clear objectives. We have to have clear roles. There needs to be flawless communication. There needs to be cooperation from everybody that's working within the team. There needs to be individual development within the team. Second portion is we have to establish strong relationships, leadership. First of all, big picture vision. We need to make sure that everybody understands what is expected from them, and the vision of the leader needs to be clearly shared. What is it that you want to achieve, and what is the goals and vision for that particular unit? We have to delegate tasks and responsibilities, communicate clear goals, be honest, respectful, and friendly to an acceptable extent. Third one is build the connection between the team. There's a lot of team building exercises that you can do in your monthly meetings. Improve cooperation amongst team members, and then encourage them to collaborate with each other, because it's difficult to work within a team if you have not been working with the team for a while. Invite contributions and collaboration. Oh, I think I've lost my fourth slide is missing. Invite contributions and collaborations. Harness the power of your employees. Invest in team building events. Monitor and review. Some questions to ask when monitoring. What has the team achieved so far? What did they change? What did they learn? What is working well? And what aspects of teamwork needs improvement? We constantly have to evaluate that. And I think we do this very well, especially if we had a code and we had to debrief after the code. We can then clearly review how we have managed that code and what kind of opportunities do we need to improve on. These are just the dimensions of involvement and creating teamwork. And I quite like this because it shows you if you have high-level communication, integration, and commitment toward teamwork, that you will have mutual planning and execution of a total plan of work that needs to be done. So the higher your rating, the more better your opportunity is for your teams to be involved and for your teams to work effectively. The last section that we're going to be looking at under leading is communication. We know that communication is the most important and is actually the foundation of the management functions, because if we don't do this well, all of our management of care processes will fall apart. Communication as a management function is the process of creating, communicating, and interpreting ideas, facts, opinions, and feelings about work, performances, organizational effectiveness and efficiency, as well as goal attainment in the organization. There are 4 common types that we are using in our day-to-day activity. Obviously, interpersonal communication, non-verbal communication, written communication, and oral communication. Which one is the most essential communication that we as healthcare leaders need to use in our day-to-day activities?
Written communication.
Yeah. Which one did you say?
Written communication.
Okay. What else?
I think they complete each other.
Okay.
I think it's the most important, effective, and non-verbal communication.
Yeah. Anybody else? I think we have to understand that each and every one of them plays a vital role in our job. Written communication has a lot of, it's very good because it's there, it's written, people can see it, they can read it, they can go back to it. But I think if you have not spoken to somebody and your written communication is not very clear, a lot of things can be lost in translation. So I do think that all four of them has to be used in together in order for it to be effective. Non-verbal communication is an essential thing that we all have to be aware of and cognizant for, because we have a lot of non-verbal communication that potentially might be a cultural thing that we cannot be used to using in certain countries. So facial expression, our tone of voice, all of those factors can be perceived in different ways from the different nationalities that we have working in the UAE. So we have to be cognizant of that. And then our interpersonal communication is essential because obviously we are working with our communities and our patients and our visitors coming into our organization. So we have to set a specific rapport with these people in order for us to get our points across. So if we don't have mutual respect and we don't set a therapeutic environment to communicate to our patients, we will not have compliance with the care plan. When we're looking at communication, obviously there's essential communication skills that you require. What do you think are, to say that you are actively listening, there's few points that for active listening to be effective. What are the points?
Again?
What is the components that make up active listening? Active listening skills.
Sure, I think not disturb the one who's talking. Sharing empathy.
Yeah.
And reflect what he said is true or not, like summarize what he said. And I understand this.
Absolutely, you've said some key points.
And also the approach, doctor. I think the approach to the person who's talking, whose views, to know that you have to be really friendly in nature to show that you are actually listening, and it's important.
Very good. Anybody else? So I think you've said the most important thing. I think the first thing that when somebody comes into you and when we are saying somebody has active listening skills is when somebody approaches you and they want to talk to you, you have to put down whatever you're doing. And sometimes we are all working on our computers. We have to stop working at our computers and we have to look at the individual. We actually have to look in their eyes so that we can have and build that link with each other so that that person can see that you are really listening to what they are saying. That's the first thing. The second thing is we don't interrupt them. We provide them opportunity to speak. And then we summarize. If we're not clear about something, we ask them and tell them to rephrase. And then we summarize whatever they have said. That way, the people will then understand that we had active listening skills. But if you're constantly listening to people and then doing other things, it's truly not providing active listening skills. You also said that the environment for active listening needs to be very professional and open, and that is also essential, because if you're busy or people pass you in the passage, you're not going to be actively listening because you were on your way to do something else. So potentially take the opportunity to take the person into an environment where it's quiet so that you can listen to them effectively. Part of essential communication skills as well is to make sure that your approach is always open and honest and friendly. And we need to make sure that that environment is set from the beginning with our employees. We need to have an open-mindedness. Sometimes we have our own personal biases before we allow people to share their things, and we shouldn't have that. We need to have a forum where we constantly provide feedback. And in my organization, we are actually doing daily rounds from leadership, and we're going around asking the people how they're doing and also giving them feedback on how they're doing themselves. And you have to have confidence. I think confidence is one of the most essential emotional intelligence skills that any healthcare leader needs to have. And we need to be cognizant, like I said to you, about nonverbals. I know many of these signs might be intrusive in many cultures, so we shouldn't be applying these nonverbals. I know as well the tone of voice and the way you speak and also your facial expressions in meetings potentially might impact people, and they might perceive you in different ways. So we have to be very cognizant when we are communicating with people, because people perceive things in different ways because we are from different nationalities. 5 tips for effective communication. We have to communicate relentlessly. Communicate, communicate, communicate. This is something that we have to learn. If you look at Sentinel event data from Joint Commission, it's constantly pointing out that the reason why a lot of events is happening is because communication failed. So I think we have truly come a long way, but we still haven't come to the essence of making sure that we communicate effectively in healthcare. We have to simplify and be direct. We need to listen and encourage input. We have to illustrate through our stories, and we have to affirm with our actions. Just if we're looking at communication, it's a process by where exchange between individuals or the organizations is made. It's the lifeline of the core team, and it's effective when it permeates every aspect of the organization. So why is it important? Effective communication, both intra-hospital and inter-hospital, is important for healthcare providers to protect their patients, save on cost, and increase day-to-day operating efficiency. For patients, the benefit is increased access to their medical history, which reduces chances of medical errors. I like this. This is from the American Health Research Group, and it's really looking at the 4 parameters, functions that you might find, and how it affects the performance and the outcomes for the patient, and communication is one of those cornerstones. We have to communicate complete, but communicate all relevant information. It needs to be clear, where we convey information that is plainly understood by the individual we're talking to. We have to be brief. We communicate the information in a concise manner. And we need to know who we're speaking to as well. If we're speaking with medical jargon that people will not understand, it's going to be lost in translation. So you have to understand your audience that you're talking to. It has to be in a timely manner. So you often request information in an appropriate time frame. You verify, and then you validate the acknowledgement that information. And in healthcare, it's essential, and we've got different kinds of processes that we have put in place over the years to make sure that we safeguard certain communication in a certain way so that we don't make errors. Where we're focusing on tools, it needs to be brief. Where we give short sessions prior to the start of something, where we're establishing the plan, discuss the team formation, assigning role and responsibility, and then we establish expectation. In the safety huddles, we're actually having safety huddles in every shift, where we re-establish situational awareness, really going on what's going on in the unit. Is there any issues that everybody needs to be aware of? Is there any patients that potentially is of high acuity or on certain medications that everybody needs to be aware of. You reinforce the plans and you assess the need and you make sure that everybody is aware of that need. And then you debrief. Is another session after an event has happened. You can speak to the team what went well, what can be improved, and what's one thing that you'll do different next time. If you do these 3 things in your organization on a regular basis, it will truly improve your activities with regards to sharing.
What difference between daily huddles and safety and debrief? Is the same?
No, it's different. The brief can be quite long. It can be a half an hour to an hour, where the safety huddle is a 5-minute session. So it's like everybody just huddling. Do you know soccer or football?
Yeah.
I think you call it football. So football, the coach will get everybody together and tell them how they need to play during the game. Or if they see somebody's doing something wrong, they get the team together and they tell them this has gone wrong. This is the same kind of concept where you're getting the nursing team together to say this has happened, this is what we need to change. Please everybody align to it. So it's just a short brief 5-second session, but it's very structured to make sure that everybody's aware of what's going on in the operational area and that they focus on that.
Sure.
So the I'm Safe checklist is where we're looking at our staff members because our team is important to us. Are they ill? Are they on medication? Are they stressed? Is there any alcohol and drugs affecting their work? Are they tired? It could be that they are mommy and they're not sleeping enough. Are they having enough eating and elimination? Because the I'm Safe is important because if you see that a staff member or one of your teammates is not performing at the level that they are performing, you have to ask these questions to see whether one of them are affecting them and then helping them, because ultimately if they're not functioning full capacity, it's going to affect the productivity of the team. And then we've got closed loop communication using call-outs and checkbacks. Call-outs is when we are in a code situation. I think we all know that, right? The team leader will say, give adrenaline 1 point whatever, IV stat, and then the person that's recording or the person that's giving the medication will say, doctor, did you say adrenaline 1 milligram stat? So that is call-outs. Checkbacks is another one, and I think we all that is part of Joint Commission IPSG number 2, where we have to, if we have a critical result, we have to write it down, and then we have to read it back to make sure that we document effectively. So all of these tools have been developed over the years because of safety events that has happened. And as healthcare leaders, we need to understand what are the policies and procedures in your organization, because definitely if you are doing codes and if you are having critical results, these policies needs to be in place. The 2 challenge rules is another safety tool that was invented by the American Health Research Quality to, if a person is identifying something that is breaching a safety event, to stop it from happening. So it's when an initial assertive statement is ignored, it is your responsibility to assertively voice a concern at least 2 times. So that way everybody understands that something is wrong. I think we all might be aware of handover tool. I don't know what handover tool is utilized in your organization, but in healthcare, we obviously have to make sure that we have a structured manner in how we're communicating healthcare information. And the SBAR is just a structured method to help healthcare leaders to translate healthcare information from one healthcare person to another. And as you can see, it's truly addressing just specific things relating to the patient, and it's easy and it makes easy for people to understand. The benefits of communication: building trust, preventing or resolving problems, providing clarity and direction, and creates better relationship. It increases engagement, and it improves productivity, and it promotes team building. So now we're going to go into our next function, which is the last function of the management of care processes, which is controlling. So under this, we have finances and quality, and obviously both of them are essential components in the management of care processes. Wills, what do you think is the components of a budget that you as a manager needs to be concerned with? Anybody? What components of budget do you look at every day?
Overtime.
Sorry?
Overtime and full time.
Overtime. What else?
Medical supplies.
Supplies. What else?
Operational issue.
So operational stuff as well, yeah. Anything else? So as healthcare leaders, we have to be, obviously, the budget components that we need to be aware of for our own areas is the budget for resources, whether it's human, whether it is capital, or whether it's consumable. And we also have to understand that we need to look at certain things, because we have to be aware of whether we are allowed to have overtime. And I think budget is quite involved, and depending on the budget that is assigned to your department, we need to know all those factors that is essentially affecting it. There's a development process, obviously collecting relevant data. So if you are working in a pharmacy, obviously it depends on how big the pharmacy is, how many patients is coming in for their medication, what kind of medication is delivered. Do they also have a separate pharmacy for the inpatient units? And how do they manage narcotics? How do they have an oncology unit? Do they have a bay where they have to prepare certain medications? So all that kind of information has to be collected before we're looking at the budgets. And then obviously the planning is essential, because you need to determine how often is the services available, and do you need to have 24/7, and is it specialized services, and you need to see how you need to plan the activities, what do you have to implement, and then you have to monitor the budget. I think monitoring the budget requires us to truly look at a lot of things with regards to our staffing, especially productivity, the turnover of our staff, the sick leave usage, and then also to see if they are in line with the volumes for the service that we are providing. And then we have to take corrective measures when necessary. Impact of global economic crisis. We know that healthcare providers across the nation are facing tremendous financial pressures. We know that operating revenue severely is constrained by shortfalls and volume growth, and this includes hospitals and physicians. Strategic spending priorities still exist, and we still have to look at our capital, physicians, and information technology. So it still needs to continue, even though there are a crisis at the moment with regards to finances. And healthcare reform, we have to look at what do we need to do, and what can we afford not to be doing now in the future. There needs to be cost reduction programs, and it has to become a priority for organization. And I think we've all seen a lot of things happening over the last couple of months with regards to people losing their jobs and many companies having to lay off many of their employees because of the financial strain. So there's a new role in focus. There's a change in focus based on volume growth may no longer be a primary performance driver. It frees us to ask what is the best care setting for the patient. And I think we all know that there's a big plan and drive nowadays with regards to making sure that we have more outpatient and preventative care rather than curative care, because we do not have enough acute care beds based on our current situation as well. Broadens our view for the services beyond just provided in the hospital, and it's intended to eliminate overutilization and overtesting, reduce readmissions, engage in primary care and disease management programs, and promoting wellness. I think there's a lot of focus that is driven towards this portion of the focus nowadays, and it's really up to us as healthcare leaders to see what is our role in making sure that we promote wellness, and moves us towards being more accountable for care integration and what happens to our patients outside the hospital. When we are hospital boards, we know that they are facing financially challenging environments. They're constantly looking at the operating revenues, the operating expenses, and then obviously the operating income. So this is essential, the new normal, and we must operate successfully under very tight financial constraints in the healthcare environment of the future. So when we look at budget allocation, it's based on a similar process throughout the hospital, but it might be open to variation depending from department to department. It's agreed with the overall management process. Obviously, it starts as part of the strategic plan, and the financial advisor sits there and he tells us what we can have and cannot have. The process is generally the same, board to operation divisional levels, and operation in division levels to the services that needs to be provided. There's two principles for budget setting methodology applied in practice. We're looking at incremental budgets and zero-based budgets. And one of the questions in your assignment is talking about the different kinds of budgets as well. So the incremental budgets is what we are having now. So if we have a budget and it's based on previous year's budget, and then they just incrementally add inflation towards that. So there's not really a lot of changes. It's just incremental change, additions or inflations that's added to your budget that you have. Non-recurring initiatives, either existing ones ceasing or new ones commencing. Full year effect of recurring items introduced partway through the previous year, and agreed new service pressures identified through healthcare planning and prioritization process. So your incremental budgets is taking what you have done in the last year and it's adding a percentage to add for inflation, and then you continue. If there's new services or new projects that needs to start, obviously you have to provide a budget based on forecasting, and then it has to be agreed by the board. And then any agreed savings that you've done throughout the year. The zero-based budget sometimes set particularly where high unit costs and lower, more easily estimated staffing numbers are involved. Process starts from scratch, building up the budget on individual post basis. You don't really have previous year's data to go on. And you culminate in a more realistic cost profile based on up-to-date knowledge and information. And it's not recommended where large number of staff is involved, and staff turnover rates throughout the year are high. So it's very limited in where you can use the zero-based budget. I think in many organizations these days, they are actually following the incremental budget because they know what they have, and it's easier just to add a inflation of, say, a 5 or a 10%.
So we can say zero budget for new project.
For a new project, you can use a zero-based budget, and many organizations is actually using a zero-based budget because you don't have data to go on. So you can just make a forecast of what you predict. So it still needs to be based on certain volumes, but it's very unpredictable because you don't know if you're going to reach your target, and that potentially can lead to you having losses.
What's meaning staff turnover throughout the year are high?
This one?
So if there is a lot of staff turnover, you need zero-based budget.
No. They say that it's not recommended where you have high turnover rate of staff. So any organizations should have, they've done studies over the years, and they say that between a 5 to 8% staff turnover rate is normal. But I think this is talking about American hospitals. But if we talk here in the UAE, it's very unrealistic to have that, because of the fact that this is not people's own country. So we will have more staff and turnover rate. But all the HR departments is actually, this is one of their KPIs, where they have to tell us what is their turnover of staff. I know in our organization, we've moved, our nursing turnover rate has moved from 8 to 15 over the last year, and it's for a variety of reasons. So we have to look at this constantly. So the staff turnover rate is actually one of the rates that your HR department is one of their KPIs that they have to monitor, and they have to discuss it with the different department levels, because everybody needs to know what is your turnover rate. And if you look online as well, it's easy to work out what your staff turnover rate is. It depends on your number of staffing, and then you divide it by the people that's leaving the organization. So it's easy to work out. But zero-based budget is, you don't really have actual data, and you're actually forecasting what needs to happen based on some preliminary results.
Doctor, just can you give me a simple definition of the zero-based budget? Simple definition.
A simple definition of a zero-based budget. A zero-based budget is just coming up with a budget where you actually, wait, let me think for a second. Give me 1 second to think. Simple. It's a method of budgeting in which all expenses must be justified and improved in a new period. So it's developed at the beginning of every budget period, analyzing the needs and cost of every function within an organization and allocating funds accordingly. So it's really, there's not really a lot, you haven't got a lot of data and information available. You're starting from scratch.
Thank you. Thank you.
The components of a budget depends on the level and extent of developed responsibility delegated to the budget manager. In practice, the key components of a board budget, for instance, will include your staffing cost. We don't have agency and other FTE cost here. The statistical and financial information for staff on individual administrative grade basis, looking at your clerical cost, your drug cost, your medical supply cost, and then, going back. The other thing that we need to add here is your capital equipment. And then obviously you have indirect cost, which is your licensing and registration cost for the organization that needs to be added to the budget. So the components of an operating budget, when we look at the operating budget, obviously revenue is essential because we have to look at volume and utilizations of our capacity and our patients coming into the organization. And we need to see if our health insurance rates are increasing. What is our case mix index in our organization? Is it quite high or is it low? Are we gaining much more from sicker patients coming in? What is the contracts that we have with the different payers? This is our insurance we're talking about. And do we have a lot of denials? And I think I said earlier on already that we have quite huge problems with regards to denials lately because of our insurance companies denying all the claims that's coming through from many of the organizations. And what are the assessment costs? What are the updates? And what are some of the other operating revenues that we're getting in, whether there's cafes and those kind of things. When we look at the departmental expenses, obviously as well, looking at volumes, how many patients is there every day? Do you have high turnover of patients? And then what is your wage rate, the benefits, the information? And then is there any new programs that you are planning that requires new positioning? And then the last thing is your capital expenses, obviously. And how much did you spend on capital? What was the interest rate? Is there any bad debt? Is there any new debt that you ask for, any new equipment that you need to be aware of? So there's a lot of things that the revenue from the expenses to the capital expenses that we need to be aware of. I know we are indirectly looking at a lot of things in healthcare. So we have to be aware that based on this, we have to look at our volumes. We need to look at our consumable usage. We need to look at overtime usage. We need to flex our staffing up and down based on our volumes. That way we can truly dictate to our corporate body that we are utilizing our staff effectively and that we are able to financially sustain ourselves. There are some different economic stuff that we can use as well. If we have to make a new project, we can utilize cost-benefit analysis, cost-effective analysis, and cost-utility analysis to aid us along the way. So whenever we decide to take an action, one must make sure that the benefits exceed the cost. Otherwise, not taking such an action is the more prudent choice. This applies to individual companies or to the society as a whole. In projects or policies affecting the society, the net social benefit measures the value to the society. Social benefits minus social costs equals net social benefit. These are some of the term formulas that you just need to be aware of, especially if you are planning to do a new project. Then you can utilize these cost-benefit analysis, cost-effective analysis, and cost-utility analysis to determine whether your project will be effective. Obviously, no one will ever take an action or adopt a policy that has a negative net social benefit. So it always needs to be positive. But the more difficult situation is when you have several projects or activities, all of which have positive net social benefits, and yet you do not have enough resources to implement them. So you have to prioritize as well. We can't do all the projects that we would like to do, but we need to make sure that we're able to do those that is required for effective patient care. So when we look at economic evaluation, both cost-benefit, cost-effective, it is a tool that is used to help decision makers allocate society's scarce resources in the most efficient way. It helps us decide which project needs to be done and which one not. And it helps us to do it in an impartial way. When markets work well, individual decisions by households and healthcare providers allow efficient allocation of resources. government intervention is justified only if the market cannot operate efficiently. When we look at cost-benefit analysis, it attempts to measure the social and private costs and benefits of a project or policy option to determine whether the rate of return to that investment is positive or not. In order to do this, all costs and benefits should be expressed in money terms so that comparisons could be made between different projects or sectors of the economy. The basic steps of cost-benefit analysis are done for each of the projects under consideration, describes the project and all its components, decide whose benefits and costs count, list all possible costs and benefits in an estimate of the quantity over the lifetime of the project. The basic steps of continued, attach a money value to all cost and benefit. You have discount, benefits, and cost to obtain present value. You compute the net present value. The net present value equals the difference between the present value of the benefits and the present value of the cost. And this is the formula that's assigned to this. You perform sensitivity analysis that we will explain later, and then you make recommendations based on the net profit value, present value. You assume that we have 3 alternatives to choose from, and we conduct a cost-benefit analysis, and the net present value of the 3 options were as follows. Which one should we choose, and what criteria should we consider before reaching the final decision? So assume that you have 3 alternatives to choose from, and we have conducted the cost-benefit analysis, and the net present value of the 3 options were as follows. Which one do you think is the best one to choose? And why?
I think that we have a high net present value, 800. We have low, 40. We have middle, 600.
Yeah. So which one?
I think 600.
That's 2,600,000.
2 million. Sorry, this is 2 million 6. Sorry, I will choose 800.
Yeah, the 800. Yeah. So the 800,000 is the one that you will, because it's the present value. Cost-benefit analysis is a clear and powerful methodology. However, there are certain instances where we cannot use this. This might occur when we are unable to put a money value on the policy impact. For example, we may be able to predict the number of lives saved by an alternative program, but unwilling or unable to put a money value on a life saved, because we have to save life. That's what our business is. We can't put a money value on it. Also, a program may have several social benefits. Some of them are difficult to evaluate in terms of money. So cost-effective analysis compares alternatives on the basis of the ratio of the cost and a single quantified effectiveness measure such as dirhams per life saved. And programs that cost less per life saved are more efficient than other programs. When we're looking at cost utility analysis, also relates to cost to a single benefit measure, but the benefit measure is made up of several benefit categories reflecting both quantity and quality. So quality adjusted life years, which combines both the number of additional years of life and the quality of the life during those years. Programs are compared on the basis of dollar per quality of life years gained. In both cost-effective analysis and cost unality analysis, contrary to cost-benefit analysis, we are dealing with more than one unit, the dirham and your quality of life years. In CBA, everything was measured in the same unit, your dirham. It was therefore easy to come up with one number, the net present value. to summarize the effect of our policy or program. I've just had this. We are in CE, cost-effective analysis and cost-utility analysis. We have a ratio between the two units that describes our program in dirhams and in value. We specified a set of alternative projects. We calculate the net health effects of each of the alternatives in COMET units, for example, deaths averted and quality of life years gained. We calculate the net cost of each alternative. We discount cost and effects to obtain present value. We apply decision rules to compare alternatives. We perform sensitivity analysis, and we make recommendations based on decision rules and sensitivity analysis. We specify alternative projects. You may have more than one project competing for the same money, right? So we need to make sure that we have essential way of how we can particularly look at which one we need to choose. You have to fully describe each alternative and details needs to be involved. Then you have to calculate the net health effects. What is the expected gains in healthy life years as a result of the intervention, and losses of healthy life years from side effects or reactions due to the intervention or the immunization. So cost of personnel, the drugs, the supply, the equipment, administrative to do the intervention, and the cost of the treatment of side effects and adverse reactions of the intervention. And when we're looking at discounting cost and effect, we have to look at cost and effect of interventions may occur at different points in time. Your immunization now prevent diseases in the future. There is a general preference for the present over the future. We need to have a method to compare cost or benefits that present with regards to the present with those occurring in the future. Discounting is the method used to quantify the presence for the present over the future, and the discounted rate is used to put all costs and effects in terms of the present. The present for the present may differ by culture or economy level. Poorer groups, for example, may have a stronger pro-present preference. Discounted rates commonly use ranges between 5 to 10%. Cost or benefits occurring now need no discounting since their value is the present value. However, a cost of 100 dirham occurring 1 year from now is equivalent to 95 dirham spent now if we use a discounted rate of 5%. And 100 dirham spent 2 years from now using a 5% discount rate is equivalent to 90.7 spent now. Discounting applies also to effects. So you can see that there's a huge drop in the value of the dirham. Decision rules to compare alternatives. When comparing several alternatives, we should use the same units for measuring cost and effects in each one of the alternatives, using AED for measuring costs and deaths averted for measuring effects. For each of the projects, we should know the cost, the effects, and calculate the cost per unit of the effect by dividing the cost and effects. What we guess should give us the cost effectiveness ratio. You may read in one study that the cost-effective ratio is 275 deaths averted. What the cost-effectiveness ratio tells us that if you choose this particular project or intervention, then to avert 1 death, it will cost you 275 dirhams. Whenever comparing alternatives, one should choose the one with the smallest cost-effectiveness ratio. Performing sensitivity analysis. A lot of details are involved in our cost-effective or cost-utility analysis, and how will our cost-effective ratio change if any of the details or assumptions change. For example, the effectiveness of an immunization was less than expected, or accuracy of a screening test was higher than previously thought. In this case, we recalculate the rate based on the new assumption and see how this affects the ordering of the alternative. So when we are making recommendations, which is the last step of our cost-benefit evaluations, cost-benefit, cost utility, and cost thingus analysis. When making recommendations, you have to consider the following. Always look at the big picture. Your results should be formed from society's perspective. The cost-effective analysis is relevant for achieving the best overall health, but not for reducing inequalities. Cost-effectiveness is only one of the criteria that health systems have to respect. Sometimes the status quo is the most efficient recommendation is to do nothing. Generally, you should recommend the project with the smallest cost-effective ratio. Don't ignore practical impediments. The most cost-effective requirements requires a budget which is larger than that you potentially have. Subgroups of the population with less than average health may cost more to reach or treat. Generally, you should recommend a project with the smallest cost-effect ratio. Don't ignore practical impediments. The most cost-effective alternative requires a budget which is larger than available. Oh, I've talked about that already. So now we're going into the last component, which is quality management. How many of you are involved in quality project in your organization?
Yes, we are involved.
Anybody else?
Yes, we are involved also.
Yes.
Yes.
Myself
so all
as
of you.
well.
That's good. So everybody is involved in quality. So quality is each and every one of our business. So we have to understand that it's one of the major sections that obviously is going to tell us how well we are performing in our different care that we are providing or the different services that we are providing in our organization. So what do you think what is quality for you as a healthcare leader? What does quality mean for you as a healthcare leader?
Doing the job in excellent way from the first time.
Very well.
Performing a task or improving the job with minimum cost, with available resource.
Yeah. What else? You all are bringing up very good points. So quality can mean different things for different people, but ultimately it all leads to the same thing, that we are trying to doing the right thing at the right time for the right patient at the right moment. So there are different definitions that we can use on quality based on our clients, our provider or employer, our management, and also our payer. The healthcare, the definition of quality can be complex and controversial because of the different views of people with a stake in good healthcare. So we have to understand that quality can mean different things. If we look at providers, they tend to view quality in a technical sense, accuracy of diagnosis, appropriateness of therapy, and resulting of the health outcomes. So they want to make sure that whatever they are paying for is meeting to the expectations. Payers focus on cost effectiveness. Obviously, they want to make sure that they pay less for a certain service, so they want to make sure that it's done at the right time for the right patient. Employers obviously want both to keep their costs down and to get their employees back to work. And the patients want compassion as well, with a skill with clear communication. They believe in heal me, be nice to me, and don't harm me. So people have different perceptions, and depending on who and where you are, you will have a different way of thinking of it. The Oxford Dictionary describes it as the degree or grade of excellence. Agency for Healthcare Research and Quality defines quality as the degree to which healthcare services for individuals and population increases the outcomes, desired outcomes consistent with current professional knowledge. And I think this is probably one of the most essential ones that is really looking at what we are doing in healthcare at the moment. So it's focusing on our own professional skills and knowledge. The National Association of Quality Assurance is saying that it's the level of excellence produced and documented in the process of patient care based on the best knowledge available and achievable at a particular facility. And in the Community Health Accreditation Program, it's described as the degree to which consumer progress towards a desired outcome. So although we have many different definitions, they all share very common elements. Quality involves meeting or exceeding customer expectations. Quality is dynamic. What might be today might not be good enough tomorrow. This is an ever-evolving field, and as healthcare professionals, we have to be aligned with that. We need to know that essentially that because we are monitoring how we are performing, we might have to change the way we have to performing as well. And quality can be improved. And before we can move on, we also have to identify what is patient safety. WHO defines it as the absence of preventable harm to the patient during the process of healthcare and the reduction of risk of unnecessary harm associated with healthcare to an acceptable manner. When we look at Donor Bedian, he's one of the quality gurus from time. He has actually taken quality to a point where he says that there's certain elements that you require that you can measure quality by. First of all, he says that you have to have structure, which is your inputs, and then that requires certain things in order for you to achieve whatever you need to achieve. So it's your staffing, your building, your patients, your equipment, your supplies, your training, and your policies. These are all related to structure. Then obviously you need a process, and that is your steps that you need to ensure whatever you have identified as in the structure or the inputs is have a certain process which leads to your outcome or your outputs. And then obviously we are measuring how we are performing and what are the things that we need to improve on. So there's a concept in quality as well, trust but verify. As healthcare leaders, we are trusting our employees, but we are still monitoring and evaluating and auditing processes to see if we are truly adhering to the process steps that has been in place to ensure that we will have a positive outcome for our patients. There's always a cost-quality connection, and so what do we expect when we go to a restaurant to buy something? We know we want value. We don't want to have food that's got no taste or it is poor quality. We want value for our money that we are asking for. Something that serves a useful purpose and is worth the cost. So we want value for our money. And when we look at the categories of cost of quality, we know that there is cost involved in quality, but these are the costs that the organization is willing to pay because it's ensuring that the patient is receiving safe care and that their performance is meeting the expectation. Obviously, prevention. So these are associated with us doing certain preventive measures and preventive checks on a day-to-day basis to ensure that the organization is safe and that we're also making sure that everybody is following the policies and procedures of the organization. We're doing appraisal of our systems to see if they're functioning in a regular basis, and this is where you are doing probably your code red drills to see if your fire systems is working and everybody understand how they need to respond. And then you might have internal and external failures that potentially is happening, and those are some of the contributing factors that is coming with the cost of quality that we have. So cost of quality, how do we calculate the cost? It's a methodology that allows an organization to determine the extent to which its resources are used for activities that prevent poor quality, that appraise the quality of the organization product or services, and that result from internal and external failures. It's comprised for the cost of good quality and the cost of poor quality, and the cost of conformance is comprised of prevention and appraisal costs. And cost of non-conformance is comprised of internal failure and external costs. So if we look at it, cost of quality equates to cost of good quality plus your cost of poor quality, and it's looking at your prevention and appraisal costs and then your internal and external failure costs. So all of them is one of the components that we have to be aware of, because this is the important reason why we have to make sure that the services that we provide is effective and that we do the right things right from the beginning, because it does cost us money if an incident happened because a staff member didn't follow policies and procedures. The cost of conformance, the prevention costs incurred to prevent or avoid quality problem, examines your quality planning, training and development, and maintaining a quality management system. Appraisal costs incurred for measuring and monitoring activities related to quality, your competency assessment, calibration of your machines, quality control, internal audits, and inspections. So these are all costs of conformance, and an organization is willing to pay for it because it's making sure that we are doing the right things for patient safety. The cost of non-conformance, this is your internal failure cost. It incurred to remedy defects discovered before the product or service is delivered to the customer. Example, instrument downtime, data entry errors, missing specimens, retesting. And then your external failure costs incurred to remedy defects discovered by the customer. This is where it leads to the patient. Harm has come to the patient and there's potential lawsuits associated based on that. Then you also have your hard versus your soft failure cost. Failure costs can be further broken down in your hard costs. Obviously, costs which are often easy to calculate, such as an additional hourly wage spent on correcting a non-conforming event that occurred, or reagents and supplies which were wasted. And soft costs, which are usually less obvious and harder to quantify, but still negatively impact the financials of an organization, such as low staff morale or the reputation damage of the organization. We know that we have these kind of costs that's happening on a day-to-day basis in our organization. It's important for us to be aware of it, because often we think that, incidents happen, we do root cause analysis, and then often it goes back to it wasn't an educational or a system defect, but it was a behavioral choice from the staff, and it could have been prevented if they just followed the policies and procedures.
Is the same risk management?
Hi.
I think in the same way of risk management.
I can't hear you, sorry.
You mentioned failure, I think, as the risk management.
Yes, it's coming to risk management, but these are more, if we have a proper risk management program in place, it should be preventing all these things from happening. But often, I think even our risk management program is not appropriate to manage all the problems that we're finding sometimes. Strictly defined, the cost of poor quality is the sum of internal and external failure cost categories. But this assumes that those elements of appraisal costs, 100% sorting, inspection, or review necessitated by inadequate processes, are classified under internal failures. This is just an example to show the direct cost that's associated with poor quality. So you can see a lot of times you think that rework and inspection and warranty and customer return, it is always on the top of the, it's visible, you can see it, but underlying that is much more indirect cost that is associated with poor quality that we have to be aware of. And us losing the loyalty of our customers is something that we obviously can't have. And excessive employer turnover is obviously also one of those things because of poor quality of an organization. So we know that we have to identify the root causes of poor quality. We have to take corrective actions or preventive actions. We need to improve quality of services, and we have to improve patient safety and satisfaction. Non-conforming event management improves patient safety and satisfaction. The degree to which health services for individuals and population increase the likelihood of desired health outcomes and are consistent with current professional knowledge. The Institute of Medicine explains 6 aims of quality improvement. So we've already looked at it in the beginning. It's where we're looking at our healthcare team value, education, training and learning, and providing a safe care environment. We are looking at making sure that we provide safe, timely, effective, efficient, equitable, and patient-centered care, and under the umbrella of strong quality indicators that guides our practices. When we look at these 6 aims, our safety relates to actual potential body harm. Timely relates to obtaining needed care while minimizing delays. Efficient relates to maximizing the quality of a comparable unit of healthcare delivered or unit of health benefit achieved for a given unit of healthcare resources used. Effective relates to providing care processes and achieving outcomes as supported by scientific evidence. And if we look at equitable, it relates to providing care or equal quality to those who may differ in personal characteristic other than clinical condition or preference for care. And patient-centered relates to the needs of the and preferences, providing education and support. There are different concepts that we have to be aware of in healthcare. Obviously, I'm going to go rather fast through them because I think many of these terms and terminologies you might be aware of. I've shared it because I think as we move along in our journey in improving our services for our patients, we have to be aware of it. We know purchasers, individuals and organizations that pay for healthcare services directly or indirectly. Cost effectiveness relates to the minimal expenditure of dirhams, time and other elements necessary to achieve desired healthcare result. Providers are the individuals or organizations licensed or trained to provide healthcare. And defensive medicine is diagnostic or therapeutic interventions conducted primarily as a safeguard against malpractice liabilities. So when we're looking at quality management blocks, obviously some of the definitions you have to be aware of. Overuse is the provision of health services that is more likely to be harm than beneficial to the patient. And quality management is a way of doing business that continuously improves the products and services to achieve better performance. Underuse is not providing a health service that might have medically beneficial, and misuse is incorrect diagnosis, medical errors, and other sources of unavoidable complications. Measurement is collection of information for the purpose of understanding current performance and seeing how performance changes over or improves over time. Assessment, again, on the other hand, use of performance information to determine whether an acceptable level of quality has been achieved by the team. Improvement is where you are planning and making changes to achieve better performance. And when we're looking at the building blocks, the cycle of measurement and assessment and improvement, obviously measurement is telling us how we are doing. Assessment is saying, are we meeting the expectations? And improvements is saying, how can we improve our performances over time? Data is required and it's facts that are interpreted for the purpose of drawing conclusions. And many of our process improvement activities that we are doing are relating to the data. So we have to be able to understand data, how to read data, and how to interpret it, because that way we will be able to track and trend to see if we're doing well or if there's opportunity for improvement. Performance expectation is the minimal acceptable levels of quality that's expected for any organization. Criteria, standards, or principles by which something is judged or evaluated. Quality control is your operational techniques and activities used to fulfill quality requirements. Accreditation standards is your level of performance excellence that organization must attain to become credentialed by a competent authority. I think often in many of the organizations in the UAE, everybody's going for Joint Commission. I know some of the HA is going for ISQA. So it depends on which company you are working for. They might have different people that accredit them. Quality assurance evaluation activities aim to ensuring compliance with minimum quality standards. And the concept of quality management is timeless. To stay in business, we have to make sure that we always look for better ways of meeting our customer expectations. Healthcare professions live by the motto primum non nocere, first do no harm. There's been a lot of quality pioneers over the years. I don't expect you all to remember it, but I think if you see their names and you see what they have developed, you'll identify and know where they come from with some of the things that you are doing in a day-to-day basis. Walter Stewart has really been working over a period of time, and he's worked really hard on coming up with the Stewart model, or the old PDCA, as we all know that, and it's used to continuously improve our quality. The other one is Deming. He's probably the most favored of the quality gurus, and he came up with learning, and he's really management is really looking at system, and it's based on the principle that each organization is composed of a system that's interrelated processes and people which make up system components. So he has 14 principles over the year that he has devised that says that in order for an organization to be effective and set of high quality, they have to apply these 14 principles into their day-to-day activities, in that way they will ensure safe quality services is provided. And if you look at these 14 principles, it's obviously many of the things that you are already doing in your healthcare settings already. So it's not anything that is new. It is part of what we do and part of how we function. It's just putting it into principle and aligning it with somebody that has actually come up with that concept in the past. Joseph Juran is another quality guru, and he came up with the quality trilogy, and he said that it's essential for us to have looking at quality control, quality planning, and quality improvement. These three form a strong basis, and they are very interrelated by making sure that we use certain things to allow us to determine how we're doing and whether we are able to function in a safe zone. So it doesn't matter what pioneer we are using. Many of the quality gurus' terminologies and methodologies is in practice in our environments now, and it's just making sense for us to why we're doing it. Ishikawa, I think we all are quite aware of him. When we are doing a incident review, we are obviously using the fishbone or the Ishikawa, and it's focusing on 6 basic elements that we are trying to identify from if you have identified a problem, and in order to identify the effect, you have to identify the causes, and then ultimately you have to, for each one of the 6 elements, you have to ask 5 times why something has happened, because that way you will identify all the root causes that has contributed to a problem from happening. And then we've got total quality management from these 4 pioneers that we've just discussed. We can see from this slide that healthcare has really grown, healthcare quality has really grown in the 21st century. So it started with Florence Nightingale, that really said in those days that we need to have a systematic review of patient. Going to Cotman and many other people that has said over the years that we have to look at standardization and making sure that we have certain processes in place to evaluate our process improvement and constantly focusing on improving the care that we provide. When we look at Donor Bedium, he was very much focused on accreditation standards, and it evolved from the 1950s to the 1960s. He examined existing research, formulating theoretical frameworks for patient care evaluation, and he is recognized for his structure, process, and outcome model of quality evaluation. And we've discussed this previously. So you can see that if you follow this, you can truly take the Donor Bedium model and see how you're doing with regards to quality in your everyday, day-to-day activity, and it will truly help you to plan for the future. When we look at accreditation, we've broadly described it before, that it's a self-assessment and external assessment process used by organizations to assess the level of performance in relation to established standards and implement ways to continuously improve them. So why do we need accreditation? It's a voluntary process by which performance of an organization is measured against nationally accepted standards of performance. Standards are based on government regulations and input from individuals and groups in healthcare industry. Healthcare organizations seeking accreditation because it enhances public confidence. It is an objective evaluation of an organization's performance, and it stimulates the organization's quality improvement efforts. So can I just ask, is anybody on the audience actually using Joint Commission standards?
Yes,
Yes.
Okay.
Yes, we are using. Yeah.
We have GCI and national accreditation. I think.
Yeah. So I think we're using JCI and a couple of other programs that's available. I know it depends on where you're from. People are using different accreditation bodies, but the most known is ISQA and also Joint Commission. So in 1930, the American... Sorry?
Sorry to disturb you. We can take only 10 minutes for break, Asr break, and break.
Okay, sure, no problem. 10 minutes.
Thank you
No
very
worries.
much. Thank you very much.
Dr. Linda,
Hi.
this is break for 2 minutes.
Yes, everybody's praying.
Okay, thank you.
Ma'am, good evening. Fahad here from SDS. I'm kindly inform all the
Can we start?
Okay, I'm here. So can definitely start because we still have quite a bit of information to share before the session is over. So when we look at the American College of Surgeons, they found that there was a lot of variations in quality. So they developed hospital standardization program to address the quality of facilities in which physicians worked. Oopsie. Training improvement efforts were also underway in nursing. The National League for Nursing Education released its first standard curriculum for schools of nursing in 1917. So around the time Stewart's work in 1920, licensing and certification requirements for healthcare providers and standards for facilities, equipment, and other aspects of healthcare became more stringent. And during the time, Deming and Jurine was advising Japanese manufacturers, and the ACS hospital standardization progress was turned over to the Joint Commission. So the Joint Commission added quality assurance standards loosely based on the work of Deming and Jurine. And quality assurance standards organizations require implement an organization-wide program to identify important or potential problems or concerns with patient care. They objectively assess the cause and scope of the problems or concerns. It implements decisions or actions designed to eliminate the problems, monitor activities to ensure desired results are achieved and sustained, document effectiveness of the overall program to enhance patient care, and ensure sound clinical performance. So you can see that over the years that the programs has really tried to improve. So it's not a constant, it's something that has changed over time and as technology and services improved. So just to overview that, we know that from the Joint Commission, they've got patient-centered, and then organization management, and then academic and medical center standards that is required from healthcare organizations. I know that many of you are utilizing it in your organizations now. It's just an overview to make sure that we all are aligned and we understand it. You can see that both of these, whether it's patient-centered organization management, it works hand in hand because both are essential in ensuring that the standards are met. So there are many other accreditations that's out there that we have to be aware of. And I know that many of you are looking at the same kind of thing. Obviously, the College of American Pathologists, they've got CAP accreditation, and it's really looking at your laboratory services to see if it's meeting the standards and requirements that a good pathology service will have. So it's looking at your turnaround time, it's looking at point of care testing, and it's also looking at how you're monitoring to making sure the quality and the integrity of the results is shared in an appropriate manner. We know that
we do have an inspection by CAP tomorrow in my institution.
Oh yeah, you see, we actually have ours next month, I think. We're actually in the process of making sure that we're meeting the standards, but nursing is working now to make sure that all the point of care education. So I know that everybody is going for CAP, but it's just a very good accreditation. I know that one center in the UAE has got the chest pain center for accredited, and it's also one of those that is meeting certain requirements. Obviously, if you're looking at minimally invasive surgery, many organizations is also going for this accreditation, and it's making sure that you have certain standards in place, because again, when you look at the Center of Excellence, it's aligning the whole team. It's not just looking at the surgeon, it's looking at all the care processes and all the teams, both nursing, surgeons, physicians, and allied health is aligned, and everybody knows what are the pathways that's required to ensure. You also have the Baldrige Excellence Framework that people are using. Many organizations, especially if you have ops gynae, is following the Baby Friendly Hospital initiative and is making sure that obviously breastfeeding is encouraged and we discourage the use of formula feedings. And then we've got the Sheikh Khalifa Excellence Award and also Dubai Quality Award. I know that there's much more awards out there and accreditations out there, but I think it's just an idea that wherever you are practicing in your own countries as well, you need to be aware of all those accreditations that's relevant to your practice, because I'm sure that many organizations is now really aiming to improve their services, and they're trying to make sure that they work within the framework of that. So accreditation is methods and principles guiding healthcare quality improvement efforts, and it's evolved at different pace than those guiding quality improvement efforts in other industries. Several factors account for this difference, and gradually healthcare is catching up by applying the best quality management practices of the manufacturing and service industries. So I think one of the biggest things that we can really applaud ourselves as healthcare professionals is the fact that we're constantly looking at improvement, and we have got very good, because we are such a complex system, we're really looking at that. So as I stated before, we need to look at a system. So in order to understand the system, you need to know where it's failing, what is going wrong, and what steps do you need to take to improve that. So what is a system approach? It's a set of interrelated parts that works together. The business organization is a system composed of subsystems, which is your management, operation, and finance systems. And it emphasizes the interrelationships among these subsystems. Its main theme is that the whole is greater than the sum of its parts, and the output and objectives of the organization take precedence over those of any one subsystem. So when we have a knowledge of a system, we recognize how things work and why, who is responsible for it, we ensure transfer of correct information, we provide patient support to wellness, we track referrals and help resolve problems, you're leading your team to excellent patient services, and you help a patient identify causes of services and make appointments. And this is where care coordination is so important. Obviously, as part of quality improvement, we have to make sure that we measure and we evaluate our performance as healthcare leaders in the industry. The science of collecting, organizing, presenting, and analyzing and interpreting data to assist in making more effective decisions. And statistical analysis is used to manipulate, summarize, and investigate data so that useful decision-making information can result. So as healthcare leaders, we constantly use the data that we are collecting to make decisions in our healthcare department. And even using decisions regarding clinical data, so it's not just about quality data. We're constantly using our clinical data to determine what the course of action needs to change from a treatment modality for a patient, for instance. So I think the doctors, for instance, if you're thinking Dr. Ibrahim in nephrology department, you're utilizing your anthropological data or your electrolytes to decide your dialysis, correct?
Sure, you are right, yes. So we use clinical data and laboratory data together to take decision and approach the patient and read diagnosis and treatment.
Absolutely. So data means a different thing for different things. And it's when we're talking about quality data, it's not just about quality data, it's also about patient assessment data, because our patient assessment data is telling us how we need to improve the care that we need to provide. Going further, if we're looking at descriptive, these methods of organizing, summarizing, and presenting data in an informative way. And inferential, this is the method used to determine something about the population on the basis of a sample. So we're making inferences about the population. And the population is the entire set of individuals or subjects of interest or the measurements obtained from all the individuals or objects of interest. And the population, if we look at the population in a hospital, it's all the patients that's admitted in a particular ward. And then a sample is obviously portion of the patients of interest. A variable is any characteristic of an individual or entity that and the variable can take very different values for different individuals. Variables can be categorical or it can be quantitative. We also can have nominal data. So this is categorical variables with no inherent order, such as your gender or those kind of things. The only operation that can be helped to apply nominal variables is enumeration. Ordinal variables with an inherent rank of order and can be compared for equality, or you can look at greater or less, but not much greater or less. Ratio variables with all properties of interval plus an absolute non-arbitrary 0 point. Your age, your weight, your temperature, these it's giving you exact thing, but it doesn't normally, you can't multiply, and divisions are all meaningful operations. Distribution tells us what values the variable takes and how often it takes these variables. And there's different kinds of peaks that we have to be aware of. If you are aware of reading data, you'll know that somebody's talking. We must show evidence of teamwork, otherwise we'll fail. There's different data collection sources. So we know that if we're working in a hospital, we get our data from various sources. First of all, computers, registers, diagnostic results, review of contents of medical records, and questionnaires from patients, staffs, doctors. And then also there's also other data collection sheets, depending on what data we're collecting. So I know for hand hygiene, the infection control champions are the ones that is doing the secret shopping, and they're the ones that's actually going around in the hospital monitoring how the nurses, the doctors, and the allied health and support services are adhering to hand hygiene practices. So you have to be aware of all the different data collection sheets in your own organization and how often it's collected and where's the data stored, who's doing it, and is everybody trained in making sure that the data is collected in the same way. Be careful of data collection. Choose a topic which does not entail too much data collection to the extent it becomes exhausted with subsequent loss of enthusiasm. We need to look at sampling, whether it's random or systematic. Only collect essential information. We have to use computers and obviously look at data collection forms. And we need to use other staff and delegate. Don't do all the work yourself. We have to, especially when we're looking at quality improvement, we have to make sure that we are actually focusing on involving our staff, especially if we want to sustain best practices and we want to sustain a culture of safety. We have to make sure that we involve our teams in our processes. And we need to make sure that we set our deadlines. And I think our quality champions on each floor is actually very involved. They know exactly what the cutoff points are and when they need to submit their data to our quality department. Sample selection. I think it's important for us to understand that it might be retrospective or it might be concurrent. Depends on what kind of information you are looking for. And it can be multi-professional. And all, because it's not just looking at physicians, it's also not just looking at nurses. If you're looking at healthcare, you need to look at how the team is performing in general. And all data should be anonymous. Remember, we are monitoring how we're performing as a system and not as a person. So that's why it should be anonymous. Your sample size needs to be appropriate. And I think we need to understand, I see that I forgot to add the slide with the sample size, but there's a specific sample size based on Joint Commission that for so many patients, you need to have so many data collected. So now that we've collected the data, what is next? So obviously, we need to have measurement. Measurement is a tool, usually a number or a statistical tool used to monitor the quality of some aspects of healthcare services. And we know evaluation is the process of examining and passing judgment on the appropriateness or level of quality or standards. Quality evaluation may be undertaken internally or externally. So we know what measures are. We've already discussed it. We've already discussed performance as the way in which an individual or group of an organization carries out or accomplish important functions and processes. And a metric is any type of measurement that we might have in an organization to gauge quantifiable component of performance. So all these data elements, definitions, help us to determine where we are and what do we need to attain. Performance measures is tools used to evaluate an element of patient care. Indicators is measures used to determine the organization's performance over time, also called performance measures. And percentages is a numerical expression indicating parts. Average is the numerical result obtained by dividing the sum of two or more quantities by the number of the quantities. It's an arithmetic mean. And ratio we've already discussed earlier on. Validity is the degree to which data or results of a study is correct or true. And then measurement data are most commonly reported as discrete numbers, percentages, average, and ratios. And the number of statistics used to report the data can influence the interpretation of the measurement information. Customer service, we know we've talked about it before, that it's activities designed to the needs of the customer. And how do we judge customer service? I'm purposely talking about this because we know that patient experience in our organizations is essential for us to sustain our business and competitive advantage. Therefore, we have to make sure that we look at our customers. Frequent measurement of patient satisfaction is important. And there are various ways how we are looking at it. There's a paper format, there's electronic, and customer care representative. In our organization, we're actually doing daily rounds with the care team, and everybody's asking the patient with regards to how the care is, how they perceive the communication from the nurses and the physicians, and whether they are happy with the cleaning. And obviously diet is one of those essential components that potentially might affect a customer's experience. So purpose of measurement, similar to the purpose of a dashboard indicator, it measuring cost, quality, productivity, efficiency, customer satisfaction, much more you want than information. You're using this information to understand your current performance. Then you identify where improvement is needed and you evaluate how changes in work processes affect performance. And then data must be accurate, useful to interpret and reported consistently. So measurement is telling us how we are doing. It has a starting point of all quality management activities. You use information to determine how hospital is performing. In the next step is assessment. It judges where performance is acceptable. And if the performance is acceptable, the organization continues to measure if it is measure it to ensure it doesn't deteriorate. And if its performance is not acceptable, advances is made to improve and improvement step. And this step might change. Changes are made. Measurement is an element of all quality management activities. and it's measured to determine current level of quality, and it identifies opportunities for improvement, and it evaluates where changes have to be improved. We have a couple of different, see double slides, sorry about that. We have 3 different types of measures. We have structure measure, which is looking at describing your organization, facilities, the environment, the equipment, the policies, and the procedures. Your process measures is describing the delivery of healthcare services, and your outcomes measures are describing the results of your process measures. So structure is, do we have the correct space, resources, competence, and capacity to provide the service, and required to have to ensure processes measures don't fail. For example, radiologist 24/7 to turn around result, critical results system able to detect and notify any issues, and temperature control for medication and food fridges. Your process measures, are we doing the right things to get there? To affect an outcome, you have to improve your process. And are the parts or steps in the system performing as planned? Examples of a process measure is when you are doing measuring your nursing admission assessment within 24 hours, because that is a requirement. The same with the physician doing his history and physical on admission within a certain time frame. That is a process measure. Outcomes measure is where are we ultimately trying to go? Are your changes actually leading to improvement? And examples of that is your hand hygiene compliance rate, ventilator-associated pneumonia rates, surgical site infections, completing the history and physicals on admission. And then we have another measure that I have brought in here, because balancing measure, often one department might want to change a process or improve a process in their department. So it tells you of changes designed to improve one part of a system are causing new problems in other parts of a system. And examples is if a laboratory automation to improve efficiency, but not involving those collecting the specimens, it affects the flow and collection process. So you have to understand that sometimes if you want to improve something in your department, you have to make sure that you involve the right people to ensure that they are involved from the beginning, because if you change a process, ultimately down the line, it might affect somebody else. And it's the same with stores indenting. So is the unit staffed with sufficient number of registered physical therapists? What type of measure is this? Structure, right? What is the rate of patient pain reduction following therapy? What measure is this?
Outcome.
Outcome.
Yes, very good. How consistently do therapists measure and document patients' level of pain?
Process.
Outcome.
Yes, process. So you can do these kind of exercises in your own organizations as well. It just helps us to understand what are the different kinds of measures that we are doing on a day-to-day basis, and we don't even realize that we are doing it. So priorities, the system and activity level measures used by a healthcare organization for quality management purposes, influenced by external and internal factors. On the external side, government regulation, accreditation standards, and purchaser requirement directly affect measurement activities. And the number and type of measures used to evaluate performance vary in proportion to the number of external requirements the organization must meet. There's core measure project as well, and as part of Joint Commission, we know that we have to be monitoring and having certain bundle compliance with regards to a variety of core measures, because they are saying if you have a bundle and you're following specific guidelines, it will minimize the effect or the side effects for patients. These are just showing some of the different kinds of priorities that's out there that people are monitoring, and that you can, and I know that probably in your organization you have a lot of performance measures that you are looking at a day-to-day basis, and also month-to-month based on your organization. And we know that there's different reasons how we choose measures. So when we're constructing measures, creation of performance measures, 3 steps that we need to take into consideration, and that it's accurate, useful, easy to interpret, and is consistently reported. We first of all have to identify the topic of interest. We need to develop the measure, and then we have to design the data collection steps system. These steps can be time consuming, but are essential to ensuring that the measures are useful for quality management purposes. So continuing with designing, to finish designing the data collection system, the manager must make 4 more decisions. These decisions address the what, the who, the when, and how of data collection. What is refers to the population that will be measured. What denominator, will the denominator represent a sample of the population to be measured or the entire population? And a sample, we've said already, is a portion of a larger group. Who is refers to the data collector. The manager or employees or quality specialists must be asked to retrieve data from administrative databases. If more than one person is responsible for data collection, how will collectors ensure they gather the data consistency? So we have to, as an organization, and I know that when Joint Commission is coming as well, they're constantly checking what system are we using to check inter-rater reliability, to making sure that everybody is evaluating and auditing the same thing. So inter-rater reliability, oh, my tongue is sticky. Probability that the measurement is free from random error and yields consistent results regardless of the individual gathering the data. For example, a measure with high inter-rater reliability means that 2 or more people working independently will gather similar data. So it's very important and essential for us in healthcare, essentially, because we're trying to involve more people in our data gathering as activities. So we have to make sure that those people that we are involving in doing some of the audits on our clinical units, they are doing it the same way. So training had to be taken place beforehand in order for us to ensure that everybody is aligned and everybody knows how to do it in the correct way, and that they also understand the tool that they have to be using. So it's of vital importance. And I think one other thing that we are also using in many organizations is to cross evaluate other people's departments. That way we really take bias out of your decision making, and you can truly say how you're performing. So just looking at the difference between measurement for research and measurement for improvement, and you can see that there's a big difference with regards. They both are focusing on improving things, but something is improving to discover new knowledge, while others bringing new knowledge to daily practices. And for research is one large blind test, and it's many sequential observable tests for your improvement. So we need to be aware that there might be differences in between measurement for research and measurement for improvement. In order for us to also understand data, we need to understand how to interpret data. I'm just going to be looking at 3 different ones in order for us to understand what they are. So a line graph, and these are ones that we potentially all the time are using in our quality data. It's a graph in which trends are highlighted by lines connecting data points. And as you can see, you can truly detect how you are doing over a period of time. So you can also then see whether you are going in a upward direction or spiraling down. And obviously this is telling you that something happened in this period of time that you have to be aware of, and you need to then, you should have taken an action plan, and this is obviously why you see that there's a spike. So something must have happened during this period of time where the team has improved their processes because they saw a dip in the data trends. The bar graph is very popular, and I think everybody is aware of the bar graph. It represents your categorical data with rectangular bars with heights or lengths proportional to the values that they present. And it can be plotted vertically or horizontally. And a vertical bar is sometimes called a column chart. So this is just showcasing, again, hand hygiene compliance. And you can then look at it over between a different few hospitals and then also between different departments. That way you can truly indicate how well you are performing and demonstrate what your process improvement activities needs to be with regards to, for this instance, hand hygiene compliance. When we're looking at the mean, median, and mode, obviously these are measures of central tendency within a distribution of numerical values, and the mean is more commonly known as the average, and the median is the midpoint in a distribution of values among cases with an equal number of cases above and below the median, and the mode is the value that occurs most often in the distribution. And this is just a graph showing you normal distribution and showing you the curves that can happen, and also showing you what is the mode, the median, and the others. So the p-values is also something that you often find in some of the things, and it's just nice to know what it stands for and how to interpret it. This is a histogram. A histogram is used to summarize discrete or continuous data. In other words, it provides a visual interpretation. This requires focusing on main points, facts of numerical data, by showing the number of data points that fall within a specific range of values. It's very similar to a vertical bar graph, but you can also track and trend and see how you're doing over a period of time. This is a very complex histogram, and many times in organization we are not using such complex things. There are many different quality improvement models out there that we have to be aware of, and depending on the situation, we can use any one of them, or we can use a combination of them. And I'm sure that if I ask you, many of you have used them. This is the model for improvement for IHI. It's asking you 3 questions plus the PDCA cycle. We also have the FADE that is focusing on focus, analyze, develop, execute, and evaluate. You have Six Sigma program, whether it's depending on where you are and where you want to be. It can be just be green, or it can be the black. Then you've got continuous quality improvement, and then you've got your total quality management. That's the 7th step. The other thing that I did not mention here, but I think you have to be aware of it, is your failure mode and effect analysis. And it is a quality improvement initiative that is taken on by organization, especially if you have a problem in a certain area. The team is working together with those stakeholders that is presenting from that particular department. And then what happens is the team will come up with what are some of the failures that potentially affect the outcomes of the patient. So the failure mode and effect analysis is a proactive approach in improving a system to ensure that everything is improved. We have done a failure mode and defect analysis this year on alarm fatigue. And we thought that alarm fatigue will be very high failure modes in all the areas, but we've identified that is more significant in our intensive care and not so significant in our emergency department, and either also not so significant in our pediatric ICU, but it was very significant in the ICU and in our NICU department. So the team came up with some action statements and improvement activities to improve that. So you have to, because I know Joint Commission is requiring all organizations to have a FEMIA. Can you tell me what are some of your FEMIA projects from your different organizations? Are you aware of what you are doing? No problem. Does
For our
anybody
organization, we are
Yeah.
for our organization, we have prepared FEMA for personal protective equipments in case of deficiency.
Ah, very good. That's a very vital one, because especially in this situation that we are constantly finding
Yes.
ourselves, that's a very nice one to do. So I think, you know, everybody needs to go back to their organizations and identify what are the FEMIAs that they have done in their organization, because I'm sure that it's there. Has anybody been involved in a root cause analysis based on an incident that has occurred over time? Anybody?
Yes.
So what was the case? Was it a error or?
Yeah, any event or significant or critical OR, we suppose, for example, in dialysis center, if the center we have, for example, 14 center in the south, if one center develop a lot of significant number of line sepsis,
Yeah.
for example, the team in the floor will do root cause analysis,
Yeah.
and according to the root cause analysis action plan.
Okay. So root cause analysis is vital, and I think it's very essential for any healthcare organization. If an event has occurred that's of significant value, that you have to actually bring the team in, because if there's such an event happening, it means that the system and the processes is not functioning effectively anymore. So obviously it has led to that process failing and an event happening, and obviously harm to have occurred for the patient. So it's essential for us to constantly, even if it's just a minor, if it's a near miss, we have to look at the root causes, because sometimes we think it's just, oh, it didn't reach the patient, the nurse picked it up. Well, something has led to that nurse not following the policies and procedures. So you have to constantly do a root cause analysis. And even if it's just a mini root cause where you just bring the nurse in and look at the systems and at the processes. We recently had an incident where in the emergency department, the patients, especially if they are a P2 and P3, are coming in. And sometimes we've discovered over the last couple of weeks, the nurses didn't have the patient documentation and obviously the identification tools to identify the patient, and they took a sample from a patient and there was a mix-up. So where we didn't realize that these practices were going on until an incident has happened. And then it brought the team together and we looked at the processes, and it's because of staffing issues that they were working slower in the reception area, and that has affected an incident from happening. So we constantly have to be aware that, you know, even the smallest event potentially can have catastrophic outcomes for our patients. So we need to make sure that we investigate all those kind of issues that is occurring. The last component under quality is obviously risk management, and it's a formal attempt to control liability, prevent financial losses, and protect the financial assets of the organization. We know that potential financial losses can occur due to patient injury, damage to the organization from theft, and misplacement of property. It is very essential for us. Healthcare risk management is quite a large program. It probably takes a half a day session as well to teach, because there's a lot of components that we have to be looking at when we're looking at risk management. Risk management is essential for us because it will help us to control our costs. When we're looking at risk management, obviously the program consists of a lot of things. So first of all, a culture of safety, and it includes patient safety. So culture of safety is looking, if you look at the culture of safety, it's looking at your leadership, it's looking at your processes, it's looking at your systems, it's looking at communication, and it's also looking at collaboration, and also what is management support. So culture of safety is essential in our organization because it's really telling us how every person that's working in an organization is focusing on patient safety. Loss prevention and reduction is another program that is required. And I think, you know, I know we've got a lot of security in our organizations, but there is obviously a lot of times potential losses that can occur, and we need to really look at how we can prevent these losses in our organizations. And I know that everybody has programs and structures in place to prevent many times loss of your consumables and your equipment from occurring. Claims management is vital risk management component, and there needs to be structures in place so that you can ensure the financial sustainability of your organization. And there's quite a lot of activities in the backhand that happens with regards to making sure that claims management is appropriately managed and that everybody is aware what their responsibility is towards claims management. Safety and security programs, obviously, if you have a pediatric program, you need to make sure that you have programs in place to secure your exits, and that you have a program in place to make sure that only the mommy can take a baby out of the organization. So that is also to protect the people that's working inside the hospital. And we have different kinds of codes set in for different kinds of events to help us to maintain and sustain the safety of both our patients and our staff members in the organization. Patient relationship program, obviously it's essential because we rely on our patients for our own financial sustainability. So we have to make sure that those structures and processes is adhered to, and that we have those programs to ensure a positive patient experience all the time. Contract with insurance premium review, obviously it's part of your financial team to be looking at the insurers that we are dealing with and setting up contracts to make sure that we're getting the money back for the services that we are providing for the clientele that is using their insurance. And employee programs and workers' compensation. Major thing when we're looking at needle stick injuries, when we're looking at work in injury in the workplace, we have to make sure that those programs is in place to safeguard and provide effective measures to ensure our staff health and that they are not harmed in any way. And I think one of the things that even during COVID time that we've identified is that during the mid-time when we had the big crisis in the beginning, we found that the quality of the personal protective equipment was not of high quality and high standard, and it potentially risked the staff safety. So it really became a problem in trying to find the appropriate professional personal protective equipment so that we don't harm our patient. And I think there was a lot of abuse during this time as well, because the vendors took opportunity and they saw this as an opportunity to exploit the healthcare industry. Resource and support system review. Obviously, this is something that we have to look at constantly. We're looking at our staffing and resources available. And if we feel that we don't have enough resources, we've got structures and reporting systems that we can report to our corporate body, because we have to make sure, and if we know that we have unsafe staffing, what are the measures that we are taking to ensure that we safeguard our patients. And then linkage with quality and utilization management. Obviously, all these components work hand in hand with each other. And if one of these components is not addressed, then obviously it's going to affect the quality and also affect the utilization of the resources that you have in the organization. So with that, we come to the end of our management of care processes. We'll overview. First of all, we reviewed the essential management functions to enable us to manage our care processes. Just to overview, what was the first function? What was the first management of care function?
Planning.
Planning. What was the second function?
Staffing.
Organizing.
Organizing. What was the third function?
Processing.
Third function?
Processing.
No. Leading.
Leading.
Yeah.
And the fourth function?
Controlling.
Controlling. So we know as well that under planning, we had goal setting and decision making. Under organizing, we had the organizational structure and HR processes. Under leading, we looked at your emotional intelligence, we looked at delegation, we looked at teamwork, and we looked at communication as it all affects. And then for the last function, we looked at finances and quality as essential components to enable us to manage our care processes safely. We've reviewed the healthcare planning cycles, the different steps, the determinants of health, and the reasons for having healthcare planning. We also reviewed research in healthcare planning. So now that we have done this program, I think you've all received your assessment that needs to be done. Right through the program, I've actually asked you, or I kept on reminding you that this is relevant to the assessment, this is relevant to the assessment. So if we can just briefly go into your assessment, and I will just, let me just open it on my. So you'll see that you've received an assignment that you actually have a scenario, and based on the scenario, you've actually got to answer questions 1 to 5. So please read the scenario carefully. It does answer a lot of the questions, but you also need to use this presentation, and you also need to use the literature and the book that I have asked the team to send to you. So it's very easy to answer. And then after this, you'll see there's a second section that you have to choose 4 questions to answer for. So it's very much in line with what we have talked and discussed today. So you have to take the information that you have led today, use the PowerPoint presentation, use the literature that I've shared with you, and then also relate it back to your own clinical setting. Because what we want to see is that you've got the information and now you're able to apply it in your clinical setting as well. So please make sure that you answer it appropriately. For, what is the gentleman's name? Fahad has also just reminded me that I need to remind you that you have to please complete the evaluation form for myself. The way I presented, how did you find the program? Is there anything that you feel that I need to improve on? So on that, is there any questions that I can answer?
Thank you, Dr. Linda. And it was really very beneficial, comprehensive. From my side, I'm clear.
Yeah, everything is clear. It was informative class. Thanks.
Hello, good evening, everyone. This is Fahad. So also it will be fine if you fill the feedback form which is posted in the wall.
Sure. Thank you, Dr. Linda. Thank you, Mr. Fahad.
Thank you so much.
If Dr. Linda, if any difficulty in question to understand or to